Good evening. In this lecture, we will discuss evaluation and treatment of urinary incontinence in a 5-year-old female child. In the year 2016, International Children's Continence Society defined incontinence as a leak and nighttime leak as enuresis. Thus, incontinence can be continuous incontinence or intermittent incontinence. It can be daytime or nighttime, which is called enuresis. Enuresis can be monosymptomatic or polysymptomatic, and then it can again be primary or a secondary where there is more than 6 months of dry interval. Among the etiology, the first important cause is voiding dysfunction or urge syndrome that comes under the diurnal functional problem. The second commonest cause is enuresis, also known as bedwetting. Uh, Neuropathic causes include spina bifida, myelomeningocele, sacral agenesis, and tethered cord. Structural causes like ectopic ureter or epispadias may also be present rarely. History taking is crucial in a girl child with an incontinence. Is it a continuous incontinence or intermittent incontinence? Is it new or has it been there since birth? And is it a problem night only or both day and night? We also have to elicit history on preventive body posturing in the form of leg crossing or squatting, known as Vincent's curtsy. Other features of bladder instability in the form of urgency, frequency, and urge incontinence. Avoiding diary or a frequency volume chart is an essential step in evaluation of these children. The number of voids is an important parameter to decide what is the course of action. The International Continence Society defined increased frequency as more than 8 per day and decreased frequency as less than 3 per day. Maximal voided volume as a percentage of estimated bladder capacity is also useful. If the maximal capacity is low, like in less than 65%, then one can think of urge syndrome or overactive bladder. If it is very high in the form of 150% expected capacity, then one can think of a lazy bladder or a deferred voiding. Holding maneuver should be elicited, and the Bristol stool chart can be used to elicit the history of bowel bladder dysfunction. The history gives an important clue to the diagnosis. A pure nighttime incontinence is usually due to nocturnal enuresis. Continuous day and night wetting, organic causes are likely in the form of epispadias or ectopic ureter. If it is an intermittent daytime wetting, then it's usually a functional incontinence. Associated bowel problems can be there in functional or neurogenic causes. In a girl child, if the wetting occurs soon after voiding, one has to think about vaginal voiding, also known as vaginal reflux, which can sometimes be demonstrated in contrast study. Correction of the posture is an important part of the treatment of this condition. Clinical examination, an expressible bladder is a feature of a neuropathic bladder, and fecal loading can be there in both functional neurogenic problems. Spine examination should look for hairy patch, swelling, a sinus, or a flat sacrum, or it should also look for a scar of a previous myelomeningocele surgery. A neurogenic bladder, one has to examine a gait, lower limb reflexes, the sacral reflexes, and the presence of any trophic changes in the foot. The local examination is essential in a girl child. Simple inspection can reveal a labial adhesion, and a separation is the treatment for this condition. A bifid clitoris can give a clue to epispadias, and the flat sacrum may suggest presence of a underlying sacral agenesis. A tuft of hair in the back may be suggestive of spina bifida occulta. When to suspect an ectopic ureter? If a girl child has always been wet, and if the genitalia is soggy like a washerman's skin, and the normal voiding cycles are there, like the bladder fills and empties with a good bladder sensation, and there are no features of instability or neuropathy, then one should suspect an ectopic ureter. The clinical evaluation and investigations should include X-ray abdomen, X-ray spine, and urine culture as a basic first line steps. Ultrasound scan should look for duplication anomalies, upper tract dilatation, bladder wall thickening, and post-void residual volume. A uroflow EMG is an important tool in the evaluation. Avoiding cystourethrogram and urodynamic examination are also very useful. X-ray abdomen may reveal fecal loading, and X-ray spine may reveal spina bifida. A spinning top urethra is suggestive of a detrusor sphincter dyskinesia, and a staccato voiding may be a feature of a dysfunctional voider. We published in the year 2005 in Indian Journal of Urology the role of uroflowmetry and electromyography in children with a lower urinary tract dysfunction. So that is a normal voiding uroflow, and that is a normal relaxation of the uroflow, the EMG at the time of a uroflow. Then we discussed three different patterns. If the uroflow shows a prolonged staccato trace with an active pelvic floor and a normal voided volume, then that is suggestive of a dysfunctional voiding, and the treatment is biofeedback. If the uroflow EMG showed a short tower-shaped curve with a quiet pelvic floor and a reduced voided volume, then that is suggestive of idiopathic detrusor overactivity, and the treatment is anticholinergics or beta agonists in the form of a mirabegron. And if a prolonged flat trace with a quiet pelvic floor is there and a large voided volume is there, that is suggestive of detrusor underutilization, and behavioral therapy or timed voiding is the treatment for this particular problem known as lazy bladder. So this is a biofeedback machine, which is the child is being taught how to control and relax the sphincter. Ectopic ureter is diagnosed with the help of a drooping lily sign in an IVU or a CT urogram, and non-functioning upper pole in a DMSA scan like this may give a clue to presence of an ectopic ureter. An MRI scan can actually reveal the presence of an ectopic ureter going beyond the bladder neck. We published our results on management of duplication anomalies in the year 2016. When the upper pole was non-functioning, we did a lap heminephrectomy, whereas when the upper pole was functioning, we performed a lap ureterostomy. In those with a neurogenic bladder, the ultrasound reveals a thickened bladder and there is a large post-void residual volume. And the voiding cystourethrogram reveals a Christmas tree type of bladder. In this situation, urodynamic examination is mandatory to look for unstable bladder contractions and poor compliance. The management of neurogenic bladder goes in a stepwise fashion. Initial management is anticholinergics and clean intermittent catheterization, and in refractory cases, a Botox is tried. If that also fails, then one can go for bladder augmentation with the mitrofenov. So we published our trial with troltolidine in those with the non-neurogenic and neurogenic voiding dysfunction in the year 2006. And we also published our experience with the distal ureterocystoplasty as a novel technique in treatment of bladder, neurogenic bladder. Last but not the least, primary monosymptomatic nocturnal enuresis, also known as bedwetting, is a common problem. And if this is diagnosed, then the child has to be asked to void just before the bed and limit the intake of liquids in the evenings. One should ensure easy access to the bathroom, and one should reward the dry nights with the help of a star charts or some gifts. Desmopressin in the form of a spray or tablets can be useful in those with the large nighttime voided volumes, and bedwetting alarms are also useful in treatment of these children. So to summarize, a detailed history taking and bladder diary are crucial steps in evaluation of a girl child with the urinary incontinence. A prompt clinical examination, it guides in the evaluation of these children. Non-invasive tests in the form of an X-ray abdomen or X-ray spine, ultrasound, and the uroflow EMG are recommended in all children. MRI scan, VCUG, and urodynamics are helpful in those with a suspected neurogenic bladder, and the management depends on the etiology. Thank you for listening to this lecture.